Hey, what's going on, guys? Welcome to another episode of the Lifestyle of Eden podcast. Today, you should already be familiar with him, with how much I talk about him, and with the multiple podcasts before this that I have with him. It is the consultant for my practice, Lifestyle of Eden, Dr. Vik Rajan. He is board certified in pediatrics, internal medicine, integrative medicine, and nephrology, which means he's a kidney specialist. And today, that's what we're going to go hammer into, being that 1 in 7 US adults have CKD, chronic kidney disease, whether they know it or not. I find it an incredibly fascinating topic, very much needed, and very much understood. I have many people that come to me and their EGFRs are very low, and they don't even know that they have kidney dysfunction and this, that, and the other because the doctors don't do full blood panels, or they're not reading this or reading that. So we're going to get deep into that today. So Dr. Vik, thank you so much for joining me. And I know for many reasons, obviously you're board certified in this, but I know that this topic hits very close to home for you. Thank you so much for joining today.
Thank you for having me again. And yes, it actually does hit close to home because I got familiarized with kidney medicine because my mom had kidney disease since I was a child, since as far back as I can remember, 5, 6 years old. We would see her go to the hospitals and kidney doctors. She had a disease called IGA nephropathy, which was an autoimmune kidney disease, which at that time, autoimmune meaning body's attacking itself, in this case the kidneys, via the mechanism of IgA antibodies. And at that time, there was no known cause, and there was no good cure. And to this day, that's still, at least
It's
on a
still the
conventional side,
consensus. Yeah.
yeah, on a
Yeah.
conventional side, there is still the case.
Right.
No clear cause and no clear cure. And now, for most people, they don't necessarily with IgA, they don't necessarily lose their kidneys, but about 1 out of 3 will. And unfortunately, my mom was one of them. And it's also for a particular type of disease, kidney disease called glomerulonephritis. Glomerulonephritis is a kidney disease where you have blood in the urine and protein in the urine, both. It is actually the most common glomerulonephritis worldwide.
Well,
And
hold on real quick because I want to let everybody know. So basically said it for us today. We're going to be the reason it hits home for you, what we're going to be talking about today is IgA nephropathy, which is an autoimmune disease that some people say is a chronic kidney disease, but in and of itself is not a chronic kidney disease. It leads to chronic kidney disease. So we'll get into that. So IgA nephropathy, let's set some groundwork. So your immune system, IgA, immunoglobulin A, is obviously a part of the immune system. It's the immune system specifically that is found within the gut microbiome, which is why on a GI map, that is what comes up is your secretory IgA, because it's within the immune system. But then obviously if that's triggered, it ends up being systemic because the immune system is systemic. And so I want to talk about IgA nephropathy because it's actually quite unbelievable to me how common it is. And as you just said with the groundwork there, is that in conventional medicine, in the past and really even in the present, they don't claim that they understand what the cause is. And this is where, Dr. Rajan, I think I need to tell the audience why I even brought you into my practice, because I always compared you with other kidney specialists. Because remember that week that we met, I was face to face with another kidney specialist talking to him about the same thing, and he threw me out basically of the office saying, no, that's not that, blah, blah, blah. And then talking to you, you were like in agreement with me. So whenever I was talking with the other nephrologist, the other kidney specialist, I brought up IgA nephropathy. And he said, yeah, we don't know the cause for that. And I said, immunoglobulin A is specifically found within the gut microbiome. And so my theory, and I think that it's a very wise theory. In fact, I'm not the only one. There's even clinics like Mayo Clinic that actually agrees with this, is IgA nephropathy. It is aroused because there's a gut infection. IgA, we can't talk about IgA nephropathy in the kidneys unless we're going to talk about the gut, because IgA is found within the gut. So I believe that it's from a gut infection or some form of a gut component, and the IgA has gone through the roof, and then now it's circulating through the blood, and for some reason, a high concentration of it got lodged within the kidneys, and then obviously causing glomerular issues and this, that, and the other. He said, no, it hasn't. And his exact words to me were, no, IgA has nothing to do with the gut. And I go, what are you talking about? It has nothing to do with the gut. So I walked out of that office, and then I had the same conversation with you, and you go, IgA has everything to do with the gut. It's literally the immune system within the gut. So you and I were on the same page with that. So let's dive deep into that with IgA. I know conventionally they say there's no cause, but let's just say screw that and let's really talk about what we really think it is and go from there. So now that we've laid that framework of what IgA is, it's the immune system within the gut microbiome, and nephropathy is a kidney issue. It's where it lodges and builds up in the gut, or it builds up in the kidney, causing damage to your glomerular function and so forth. Let's talk about IgA. So go ahead, Dr. Rajan.
Yes, what the putative cause is some sort of infection, typically some like a viral infection that you may get. For most people, viral infection, like whether it's the upper respiratory or gastro, whatever, it's innocuous, comes, goes, that's it. Now, some people, it ends up leading to a hyperimmune response. With long COVID, a lot of people got COVID, most people did fine, some people did not. They ended up having symptoms well beyond the typical time period for COVID, and they get tired, weak, all sorts of weird dysfunctions, and because it's triggering some sort of immune reaction. And in this case, with IgA nephropathy, some sort of viral infection ends up causing a immune dysfunction with IgA, which is a secretory antibody in the gut. Also, interestingly, anywhere in the body, from even in the pharynx, tonsils, and gut, all of it. It can make secretory IgA as part of your immune system to keep foreign organisms, invaders out from going inside, right? The common secretory antibody. But when you get a hyperimmune response, then it's some of that potentially then goes in and then lodges in your kidney and creates all sorts of reactions. IgA is one of them. There's also immune system and immune reactions can be complicated. There's like complement and all sorts of factors in the immune system that get built up in the kidneys and then cause damage to your glomeruli, and then you get this kidney damage. And so one of the things though is that traditionally, if you had IgA nephropathy and it was bad enough, like I said, some people it's not bad. They get minimal symptoms, they're not getting significant kidney damage. But in the case of my mom, it was bad enough. She was getting substantial kidney damage.
Real quick, Dr. Rajan. So with you have primary IgA nephropathy, and then you can have like secondary IgA nephropathy. Isn't the liver responsible for cleaning out IgA? And then therefore, if there's a liver issue, you can actually have secondary IgA nephropathy because it's not able to filter out IgA properly. Could this also be a liver issue?
Potentially. So there's IgA nephropathy, the primary is said, and there's also other things. For example, you can get IgA nephropathy. One common way that we know of that happens is actually, I mean, the liver issue, but gluten, celiac disease. And so celiac, with that, it's also an IgA mediated immune
Yeah.
dysfunction. And so some of those people, now that one with the IgA, they don't tolerate gluten, and you can actually test for that. The testing involves an IgA antibody testing for gluten-related protein, and then having an immune reaction to that. And so now celiac traditionally is in the gut, but some people end up getting it also in the kidneys it's like secondary IgA.
Well, you just brought up an interesting thing. So, being that celiac is an autoimmune disease, and being that IgA nephropathy is, although it ends up being a kidney issue, it is an autoimmune disease. Every autoimmune disease on the earth, however many we want to say there are, 100, they're counting by the day now. But however many we want to say there are, every autoimmune disease, what's actually interesting about this is I'm connecting this in my mind right now. Every autoimmune disease has leaky gut at its root. Every single one. So how can a kidney specialist tell me to my face IgA nephropathy has nothing to do with the gut microbiome when it's an autoimmune disease and every autoimmune disease is rooted in leaky gut? Therefore, it's absolutely a gut component.
Because they don't understand functional medicine and the role of the gut in autoimmune dysfunction. And so, look, I've even once talked to a rheumatologist, which is specialized in autoimmune diseases like lupus and rheumatoid arthritis and all this stuff. And I said, and the person I knew from back in residency was trained in internal medicine. And she went into rheumatology, I went into nephrology, and I had a patient that brought to her for a consult, and had some sort of, I think, rheumatoid arthritis. And at the time, I was saying, you ever have patients that, you put them on like a gluten-free or dairy-free diet, like elimination diet. You ever have them ones, they do that for themselves. She doesn't do that. So you ever have patients that do that, and then their arthritis, their autoimmune gets better? Like, yeah, I get that every so often. Like, how come you don't talk about that? That's not what we're trained in. That's true. That's not
So
what they were trained in. They have to have trained in something else to even realize that is potentially part of the cure.
so hold on. Okay, this is interesting now. Now this brings me down a line of thoughts that is fascinating. Okay, chronic kidney disease, CKD, although IgA nephropathy is not chronic kidney disease, it's an autoimmune disease. It'll lead to CKD because it damages the glomerular function, which obviously EGFR and glomerular filtration rate is literally over the course of more than 3 months is actually what defines by definition CKD. But or proteinuria or hematuria, one of those three. But anyway, what's interesting here is that 1 in 7 US adults have CKD, chronic kidney disease, whichever state they're in, they have it. And IgA nephropathy leads to chronic kidney disease. And IgA nephropathy is an autoimmune disease, which is leaky gut component, and it's rooted in the gut microbiome because of leaky gut being the root of every autoimmune disease on the planet. If leaky gut causes IgA nephropathy, and then IgA nephropathy can end up causing CKD, the root of somebody's CKD and their chronic kidney disease in that case is actually the gut. And we're not even connecting that because we're not thinking functionally, when really that's what we need to be attacking to either do one of two things, either reverse the CKD or at the very least, to stop it in its tracks to where it doesn't get any worse. This is all functionally minded concepts here that is totally foreign to conventional medicine. And not only conventional medicine, but just nephrologists in general.
Yes, it's so interestingly, when if you're having bad enough IgA to where it's affecting your kidney function, right? So the traditional treatment is immunosuppressants like steroids, for example, right? So you're suppressing the whole immune system in general. What's interesting though, I think in the last, let's say, probably 10 years or maybe as little as 5, is that steroids in general, you're taking it systemically, it causes other untoward effects. It makes you gain weight, puffs up your cheeks. It can lead to osteoporosis. It can raise your blood sugars, any number of things when you're on it for a long time, right? So what they ended up creating more recently, because they found this, is make a targeted budesonide instead of prednisone. Budesonide is a steroid, but it's targeted specifically for the gut in an area where there in the terminal ileum where there's a lot of Peyer's patches, like part of the significant immunological area of the gut, and they've created this budesonide to target that. And so and that seems to help and it reduces the side effects. But here's the thing: if you fix leaky gut, then your body will fix it itself. And what was interesting was that some years ago, I think it was about 7 years ago that I recall, I once actually had someone that had IgA nephropathy. I had to get an appointment with his nephrologist and to go, and he had pretty advanced kidney disease. It was stage 4, which means that a significant amount of his function is gone, like 15 to 30% is what's left. So somewhere in that range. And once your kidney scars, yeah, it scars. You can't get that back. But he wanted to see, is there anything you can do besides conventional treatment that could stop the injury and from further progressing? And several things. One, go on an elimination diet, and then 2, take fish oil, high dose fish oil. And he did those things. And a couple of interesting things happened. One, he lost 15 pounds. His blood pressure went down. But more importantly, his proteinuria, which is the kidneys are supposed to filter properly and also keep. You shouldn't be spilling too much protein into your urine. If you're
Should you be spilling any protein into your urine?
a very small amount, right? Maybe 50 milligrams. But if you're spilling like a gram, couple of grams, 3 grams, 4 grams, that especially if above 3.5 grams, that becomes called nephrotic range proteinuria, and that will damage your kidneys in and of itself. because like the damage leads to spilling more protein, which leads to more damage, which leads to spilling more protein. You've got to do something about that. Otherwise, you'll end up progressively going to kidney failure in a number of cases. And so in the process of him doing this elimination diet, then if it's a gut related thing, then it should help decrease your, hyperimmunity, and then thereby improve your numbers. His proteinuria went down from 3 grams to less than a gram within a span of a few months. And this is before he met the nephrologist and doing any conventional medications. This
Wow.
elimination diet and fish oil. And I thought this is really interesting. I wonder if anyone has ever studied elimination diets and IgA nephropathy. And it turns out there was someone. There was a group somewhere in Italy back in the early 90s, early to mid 90s. And they published a couple of studies where they did elimination diet.
In theory, obviously it makes sense because anytime you have a gut issue, you have to go on some form of elimination, especially gluten.
Yeah.
And so by doing that, you're sealing up the leaky gut. Then as a byproduct, of course, you're going to fix the IgA nephropathy, right?
Yeah. What happened was that in this limited study, they had a number of patients for this and put them on this elimination diet, and they found that their proteinuria significantly improved. It went down by 70%.
Yeah.
But that was all that there was after that. There's no other studies I could find published since that time. Certainly not anything I learned in my nephrology fellowship in Baylor College of Medicine. And I didn't even know about that study when I was trying. I was just trying. It's like, hey, let's see if, because it works for all sorts of immune dysfunctions. But then when I was preparing for your podcast, I was looking. It's like, let me see if anyone else has done this. They did. They already did, but no one ever took it up after that.
Let me ask you this. Okay, so like on the app that me and you will use, where we can type stuff in and find medical, this, that, and the other, it talks about chronic kidney disease is diagnosed by one of two things, hematuria or proteinuria. But the third one is depending on your, like, for example, if your EGFR goes 57, for example, if it's there for a minimum of 3 months, that is when you can officially diagnose chronic kidney disease. So by definition, anybody can just test themselves and go over 3 months, and you can just diagnose yourself technically. It's like diabetes. If you have a A1C over 6.4, then you can diagnose yourself. Hey, I'm a type 2 diabetic now. Okay. So with IgA nephropathy, chronic kidney disease, we know how to diagnose, but IgA nephropathy, how do you literally diagnose for IgA nephropathy?
Technically, the gold standard is a kidney biopsy. And then you'll see particular changes with the IgA deposition in the glomeruli. But having said that, it doesn't always require a kidney biopsy if you have the right clinical story, usually in the context of someone with that hematuria, proteinuria, it's a glomerulonephritis. And that's some of the criteria. There are different types of glomerulonephritides as well. And there's tests that you check for to see if there's anything else, because there are other potential causes of kidney disease. The most common ones are going to be high blood pressure and diabetes, right? But assuming they're not high blood pressure, they're not diabetic, and then you test for other things. Could they have HIV? Could they have hepatitis? Could they have cryoglobulinemia? Could they have lupus? Could they have any of these other things? And you go through all this litany of different possibilities. You can't find anything else. And they have this, like I said, hematuria, proteinuria, and everything else been ruled out. It may be IgA nephropathy. But like I said, if you want to, but the gold standard, they do this for someone who's having progressive kidney failure, then they'll do a kidney biopsy, and that's the definitive way to say that this is IgA nephropathy. And then what's next after that? Like I said, it depends on how bad the kidney failure is. Again, not everyone with IgA nephropathy gets kidney failure. About 1/3 will.
Let me ask you this, because like I said, I know this is personal because your mom, before she passed, had IgA nephropathy. Knowing what you know now and realizing, hey, this is 100% a gut component, this is 100% leaky gut rooted. Do you think that, and obviously you hear about how many cases I deal with where I'm writing these gut protocols and dealing with the gut fix. I just had another call yesterday. Person just finished his gut protocol for 6 weeks. He's good as new. And he had H. pylori, SIBO, leaky gut, all this different stuff, and fixed it all with herbals and my own protocols. Do you think that the partnership that me and you now have going from these root cause things, this, that, and the other, do you think that your mom may have had a better outcome with her IgA nephropathy if she was here today and we were like, hey, let's fix the gut, and knowing what we know, do you think that could have changed anything?
Yes, I think it would have. Of course, I was back in, wow, 40 years ago. 40 years ago. Back then, there was hardly any knowledge of functional medicine at that point. There were maybe a handful of practitioners in the entire country.
So
And
the stuff that you and I talk about always in our private conversations or even here or whatever, this stuff you don't this is not okay. So here, Dr. Rajan, I want them to hear it from you. You're an MD. So everybody always asks me, like in my Facebook group the other day, I just went in and was discussing T4 to T3 conversion in the Facebook group. And I was talking about how mercury binds to the enzyme that is responsible for T4 to T3 conversion. So that's why a lot of times it's a heavy metal issue or whatever. And they said, Nick, and this woman that commented is one of my clients who is also a nurse. I have multiple nurses that are my clients. And she said, Nick, why do the doctors not teach us this? And I said, listen, I don't think they're doing it nefariously or in any type of way. They don't learn this in medical school. Would you agree that these concepts
yeah,
that they're not taught in medical
yeah,
school?
they don't, yeah, why do they not teach us this? Because we didn't learn it. I didn't learn it. I learned it only if after studying integrative medicine. And then and by the way, when I was studying it, there was no residency or fellowship programs for this. There still isn't in the city of Houston. Houston is the biggest medical center in the world. There's no program for integrative medicine, or functional medicine, or anything like
Yeah.
that. You
And so
have
just
to,
so, just so that the crowd knows, when Dr. Rajan says integrative medicine, he's talking about integrating functional medicine with conventional medicine. He's integrating both of those. So that's what he means when he says that. Keep going, Dr. Rajan.
yeah. I didn't even know, except a friend of mine told me this is you can learn it online and get board certified in this. And so that would have been my fourth board certification. I said, sure, why not? I didn't realize how impactful it was going to be because it upended everything that I thought I knew about outpatient clinical care and made me realize that everything we do on the outpatient clinical side is missing the point.
Think about it. Think about this, Dr. Rajan, our conversation we had like 2 weeks ago, where my client, who she's got a plethora of issues, but two of her probably 10 issues is PCOS, which she has three of the four kinds of PCOS, and severe endometriosis. And she texted me the other day the screenshot. She went and had an ultrasound done. The doctor said, we don't know what you're doing, but keep doing it because your ultrasound, we can't even find that you ever had PCOS or endometriosis. And in medical literature that I have found, that has actually never been done in the history of any medical literature I've ever studied where you can literally, where the endo is literally, it's not even found, it's non-existent, it's not even being shown up. And that's totally not conventionally thought or founded or whatever. So I think it's interesting that we can do so much that we've underestimated through natural and lifestyle means, which you always talk about with your algorithm of six, my six pillars that I talk about, and this, that, and the other. And like I said, that's the reason why I'm so fascinated with you is even when we talked about the sirolimus, the rapamycin,
Yeah.
right? It was like what I taught you about rapamycin, you will never hear in conventional medicine about how, okay, you use it as an anti-transplant rejection drug. This is actually one of the greatest natural fungus found drugs on the planet that actually induces autophagy and puts your body in a fasting state. But that same week that I was talking about that other nephrologist, I talked to him and you, and I talked to him about two concepts. One was IgA nephropathy, one was sirolimus rapamycin. He basically kicked me out of the balloons. He kicked me out of his office for that concept. Meanwhile, the next time I met with you for coffee, you went and actually read a book about it and was like, wow, not many doctors are like you where they're willing to continue learning. It's, oh, I didn't learn this in conventional medicine. So no, it's just, that's where it's at.
Yeah, sometimes I've discovered over time, sometimes the best ideas in a particular field that come from people who are actually outside of the field. Because when you're in a particular field and there's a certain line of thinking that you're taught, everyone else is taught, and everything is built off of that. But then what if the premise of that was incorrect in some ways? And again, it's not that all of conventional medicine is incorrect. For example, I find if in acute medical emergency care, hospital care, if you're having a heart attack, let's say, probably don't go to the naturopath first for some herbs and spices. Go to the emergency room and get a cardiac cath. That is a medical emergency that you need to get stabilized and save your life. But afterwards, you should probably talk to a functional specialist about what caused the inflammation that led to that heart attack in the first place, because it's not simply a cholesterol issue. And so it is, yeah, that's what it is. So sometimes there's been folks from outside that come in with a unique approach that ends up actually transforming the field that they're looking at for the better. But there's always resistance, of course, right? Because this doesn't jive with what we've been doing or what we've been taught. Maybe, but what if it's better? What if it's better? And it takes time. You have to prove that, because again, a lot of ideas from the outside may not necessarily be right. I mean, like how many people look at Google this and Google that, and it ends up leading to misinformation that leads to bad outcomes. That happens a lot too. But sometimes it ends up to leading to something that is right, and you have to be willing to keep an open mind to distinguish between those two. And
So
again, for me, it's all about results oriented. I don't really, I'm not particularly plugged strict about where it's coming from, as long as it leads to the desired outcome. In a sense that, like, the end justifies the means, even if it's coming from an outside source. If this is leading to a better outcome, then it should be considered, not from the conventional medical world.
so with all, because 1 in 7 US adults have CKD, and a lot of CKD is being done because of IgA nephropathy, which IgA nephropathy is rooted in a gut issue because it's leaky gut, because it's an autoimmune disease. If somebody comes to me, because I get a lot of clients that come to me and they don't even know they have CKD until I'm reading their blood work and I'm looking at their past labs and blah, blah, blah. When that happens, I immediately address the two low-hanging fruits. The two most common causes of CKD in the United States of America is, as you said, diabetes and blood pressure. We look at those. Okay, let's check that out. Then, we go, okay, let's lower the protein a little bit. Let's see if the body starts to process better. Let's just see if the creatinine, the BUNs, EGFRs, let's start to relieve some stress. Let's fix this. Let's fix that. At what point do you go, well, not only at what point, but then how, let's just say in my case, would you go, okay, let's see if this is an IgA situation. Now, if I don't want to do a whole kidney biopsy, when I get a GI map, if their IgA, their secretory IgA is through the roof and all those dots, can you start to connect those dots and go, okay, maybe this is an IgA nephropathy situation?
Potentially, yes. So there's, like I said, first of all, the most common, of course, is diabetes and high blood pressure by far. That's going to be like 80+%, right? And so then, but then you have other things. Now, IgA in particular, you have to have both hematuria and proteinuria. That goes together with it.
So the next thing that I should be doing then is a urine analysis.
Urinalysis, yes, that's nephrologist is urinalysis called a liquid biopsy of the kidney. Short of sticking a needle in it, the urinalysis, and it's a comprehensive one, because there's a urine dip that you can get. Even a layperson can get over Amazon and dip it, but that gives you just a rough idea. But you need a microscopic urinalysis, because which is something that has to be done in a lab, and that'll tell
Will the
you
urine, will the urine dip that you can just get from Amazon or whatever, will that tell me if you have proteinuria or hematuria?
it'll give you some ideas of it. But
So if those show up, then I don't really
yes.
need to go further. If it smells like a horse and it tastes like a horse, it looks like a horse, it's a horse,
Yeah,
right?
but at the same time, it's not. But you also want to get a better quantification. And again, those aren't the most sensitive tests. There's, for example, we use that for a urine dip. You may see for just a UTI, right? Doesn't always pick it up. They have the symptoms, but it's not. But it's not always sensitive. It's like they may have no leukocytes or trace leukocytes, but they clearly have a urinary tract infection. Now, if you did microscopic, you would see the white counts more significant. And the dip gives you an idea, but the microscopic analysis gives you a clearer picture in terms of what you're dealing with. And it's particularly sometimes it'll tell you about casts. So one of the things you may sometimes see, not often, but if you do, it's called a red blood cell casts. That's a particular finding of a type of sediment that you see in urine. Again, it's a microscopic analysis. You cannot get that in a dip. But labs will tell you if you see that, or if you see that particular thing, that is specific for glomerulonephritis. Now, you don't. Now, not all glomerulonephritis will show up with that red cell cast, but if you see that, that is glomerulonephritis right there.
If you see what?
It's a finding called red blood cell casts. And so again, that's something that would be commented on in a formal lab, and they would look at it. They would comment and say red blood cell cast noted. Again, it's pretty rare that they can comment on it, but the few times they have, that is considered pathognomonic, which means
And
if
that's
it's
not related to myoglobin. That's not related to myoglobin.
no, it's not. That's a totally different thing.
Yeah.
But yeah, you get a urinalysis and preferably full urinalysis with microscopic analysis. And other things too, you need to rule out any other secondary causes of kidney disease.
Like a
And
liver issue.
well, liver, but also, like I said, there's a battery of tests that we get to see what may cause it, and that may be like an ANA to look for lupus, you may get HIV or hepatitis panel, or like a SPEP, UPEP that checks for multiple myeloma, cryoglobulins, and it's like C-ANCA, P-ANCA. These are all sorts of fancy tests that we get in the nephrology world to see what are the secondary causes of kidney disease you could have, especially if we don't think it's simply a diabetes hypertension issue. And even for that matter, obesity, morbid obesity can also lead to an autoimmune kidney dysfunction as well, just in and of itself. So a number of things. In the IGA is the most common cause of kidney disease in the class of glomerulonephritis. Glomerulonephritis is just one class of kidney disease. Again,
How do you know? How do you know to go down the route of searching for glomerulonephritis, or how do you test for that? How do you what do we do with that?
so glomerulonephritis is going to be, like I said, you're having issues with
Your
hematuria.
EGFR will obviously be lower, right?
It may. Sometimes it's not if it's early, but you will see things like hematuria, proteinuria, hypertension, and possibly some decrease in your GFR, your kidney function. And it depends on how advanced it is. Again, like even with IgA nephropathy, there are people who have uh, a reasonably normal kidney function, but they do have IgA, they have the hematuria, they have proteinuria, they may even have high blood pressure, but their kidney function is still preserved. But again, there's a number that won't have normal kidney function. It'll progressively decline, and 1/3 of them go to kidney failure and end up needing a transplant. And that was my mom's case. And she ended up needing it twice because for various reasons. One, transplants don't last forever, and so you may get years out of it, but then you may get either chronic rejection or sometimes IgA nephropathy can recur because again, yeah, you may have replaced a damaged kidney,
You didn't
but
fix the
it's a
root.
gut issue and you haven't fixed that part, then it can come back and affect the transplanted kidney as well.
Exactly.
So
Wow.
so you
Wow.
ultimately you got to look at
Is that what happened with your mom?
it went to failure, and at that time they said it was chronic rejection. Maybe that does happen. I sometimes wonder if it was also the IgA recurring as well, but I don't know. Like I said, she passed away years ago. But
Hopefully in I'm that's one of the reasons why I know you're passionate about this. And hey, you know what? It is such a need right now. 1 in 7 people have kidney disease and this, that, and the other in the United States. And hopefully because of what happened with your mom. What was your mom's name?
her mom's name was
Komala?
yes.
Yeah, and the name of in honor of Komala, man, God willing, through our partnership and with my practice and with CIM, concierge integrated medicine and everything else, hopefully now with the knowledge that we have, that if she was here now, we could have really helped her. Hopefully now we can pay that forward.
Yeah.
and really benefit a lot of people because of the passion that was built and birthed in you because you personally watched this firsthand with your mom.
Yeah. That was actually one of the things I went into medicine and saying, it's like, Mom, I'm going to find a cure for your disease. And at first I thought it was going to be some sort of bench research and find this drug or that. I had never thought it would be, it's actually functional medicine and healing and potentially healing the gut and that algorithm of six and all those things. But when I saw that study of these guys who did this in the 90s, the early to mid 90s, that is a potential that needs to be studied further. That needs to be studied further. Now, this was like some obscure article in that was done by a group in Italy, and after that was it. Like this needs to be looked at in America in a major way. Of course, you'd have to raise enough money to create research dollars to attract enough doctors that are willing to try this out and create a significant trial out of this. And then if you see assuming you see the success out of it, then you build on it and you build that momentum and get it in the conventional world until they realize that you actually need to put a functional medicine approach to all of these autoimmune diseases, IgA nephropathy just being one example. And
This is good. This is good, especially being that we're always discussing a certain case like IgA, but we don't stop at IgA. We go, what was the reason for IgA? And it's gut. Like I said, I think it's amazing that the same week that I met you, I had a debate with another nephrologist, and you two, y'all come from the same field, but worlds different in understanding and open-mindedness and everything else. That's how all this was birthed, was because another nephrologist that I was wanting to bring these theories to basically threw me out of his office because
yeah,
he said, no, it can't be this, it can't. And I'm like, I don't understand how you're not seeing what I'm seeing. The IgA is literally gut immune system. So what's going on? So this is good because we're teaching people, okay, IgA nephropathy is an autoimmune disease which is rooted in the gut, but it's also a major root, IgA nephropathy, leading to chronic kidney disease. If you have that, don't always focus on the thing that's in front of you. I always tell people when it comes to medicine, when it comes to the functional space, when it comes to healing this, that, and the other, and reversing disease, reversing illness, whatever it may be, is sometimes it's not the thing that's there that is what we need to focus on. It's why is that thing there and what caused that thing to be there. And whenever you start to focus on those different things, okay, the chronic kidney disease, then you can start to ask yourself, okay, you have the chronic kidney disease. It could be because of IgA nephropathy, and that could be obviously because of the gut. And we start to transfer people's minds into the right direction. I think that's awesome.
yeah, yeah. It's something it's an approach that needs to be done in the conventional world. But again, the other nephrologist you talked to, he didn't train in that environment, right? I didn't train in that environment. I only learned it starting in 2014 when I started studying integrative medicine, and specifically the functional medicine aspects of it. Otherwise, I wouldn't have known if you asked me 20 years ago. I'm like, what does that have to do with
Right.
it? It would have
Right.
I wouldn't have understood it either. So that's the thing. It's just
Yeah.
you don't know what you're not taught. And
Right.
this is and again, just like how that same week, look, I wouldn't even know unless a friend of mine said, "Hey, you want to get your fourth board certification without having to take another residency or fellowship?" Sure. What you got? There's this thing called integrative medicine, and you can learn it online. And then study it in some clinics that do functional
Wow.
medicine, and then take a test, and then you're board certified.
There you
And I
go.
was like, why not? And then it changed everything for
Yeah.
myself and for my patients. And now here we are.
That's right. Man, this has been great and I think very informative for the audience. I think it's, even though it was on IgA nephropathy, I think showing the chains of events, how one thing leads to another, and we need to go back to the root to fix that so the chain stops and falls over like dominoes, I think is critical and very eye-opening to a lot of people, man. Dr. Rajan, always super thankful to have you on and obviously just to be partnered with you in my practice and everything else and just to know you and learn from just such a wealth of knowledge like you are. So once again, man, thank you so much for joining. And I know that I was blessed. I know the audience was blessed. So I appreciate you coming on.
Thank you for having me again.
Absolutely. Well, guys, thank you guys for listening. Stay tuned for the next episode, and we'll talk to you soon.